because we know that few things are very important, like sodium intake and protein intake, and it varies from the stages of kidney disease. So we will discuss in detail what about the kidney disease, how they progress, what are the causes, and how the nutrition can help in management of renal dysfunction. So kidney disease are among most important cause of death and disability throughout the world. Kidney failure is a major cause of loss of productivity and environmental financial burden. So here we can see that kidney has been shown. One side is a healthy kidney, another side is an unhealthy kidney. So kidney has important function like sodium and water removal, waste removal, and many hormonal production like active form of vitamin D, erythropoietin, and different other functions. And on the other hand, if the kidney is unhealthy, so it will lead to fluid overload, increase retention of urea, creatinine, and potassium, and change in hormonal function like blood pressure control is disturbed. So patient presents with hypertension. Then blood anemia. Anemia is also important component because of deficiency of erythropoietin, and electrolyte imbalance like hypocalcemia and bone mineral metabolism is disturbed. So now, different types of kidney disease. Based on the duration and rapidity of onset, we can divide in majorly into two parts. One is acute kidney injury, and another is chronic kidney disease. So, acute kidney injury, previously known as acute renal failure, and it refers to sudden decrease in kidney function and evident by oliguria, urine output less than 400 ml per day, and retention of uremic molecule solutes. So it results in retention of urea and other waste product, and dysregulation of extracellular volume and electrolytes. So, and on the other hand, the chronic kidney disease is actually structural and functional abnormality of kidney for more than 3 months, and it is characterized by gradual, irreversible loss of large number of functioning nephron due to extrarenal cause, cardiac insufficiency, diabetes, hypertension, and in intrarenal cause of CKD includes glomerulonephritis, microangiopathy, nephritis, polycystic kidney disease, and many other obstructive uropathies. End-stage renal disease is called when the renal replacement therapy is must, and it usually comes when the kidney function remains only less than 10%, and when there are different causes which affect the blood vessel, glomeruli, interstitium, and urinary tract. All may lead to kidney dysfunction. So, coming to the chronic kidney disease etiological classification, first is immunological causes like glomerulonephritis, then among metabolic causes, diabetes mellitus or amyloidosis are main important cause, then vascular causes like atherosclerosis leading to ischemic nephropathy and nephrosclerosis, then infection-related causes like chronic pyelonephritis, tuberculosis, then some tubular defect like because of several nephrotoxins like analgesic and heavy metals leading to tubular disorder and ultimately causing chronic kidney disease. Then obstructive causes like renal calculi, prostate hypertrophy, then urethral constriction, so leading to retention of nitrogenous waste product and ultimately leading to chronic kidney disease. Then several congenital causes are also there like polycystic kidney disease and congenital absence of renal tissue. So, among the causes of ESRD, we can see that diabetes is the most important cause, leading cause causing 40% of the CKD ESRD, then followed by hypertension, around 27% cause of ESRD is because of hypertension, followed by glomerulonephritis, around 13%, then interstitial nephritis, around 4%, then cystic and hereditary causes, around 3.4%, then some tumor-related causes like 1.7%. Then coming to the stages of CKD, based on GFR, the stages have been divided into five parts. If there is structural and functional abnormality and GFR is more than 90, then it's known as stage 1. Then stage 2 is mild decrease in GFR, 60 to 89. Then stage 3 is from 30 to 59 ml per minute per 1.73 meters square of GFR. Then stage 4 is characterized by GFR of 15 to 29. And if the GFR is less than 15, That means it is stage 5 requiring the dialysis. So this type kidney staging of kidney disease is done, and proteinuria also is important in characterization of the CKD. So as we go from stage 1 to stage 5, there are the severity of renal dysfunction increases. So initially stages we should screen for underlying cause like hypertension, diabetes, obesity. Then uh, we need to control the blood pressure, control the sugar, and weight loss is also important factor in decreasing the progression of kidney disease. Then, as the stage further progresses, like in stage 3, we need to manage complications like uremic complication, management of anemia, prevention of malnutrition. And when the further stage increases, like stage 4 and 5, we need to explain the patient about need of renal replacement therapy and management of fluid and blood pressure and the underlying cause like diabetes management. And as the stage progresses from stage 3 to 4 and 5, there is a disturbance of mineral metabolism. So calcium phosphorus management is also important part of as the stage progresses. And at the stage of in stage renal disease, we need to prepare him for dialysis and transplantation. Now coming to the metabolic picture of renal disease, so because of accumulation of metabolic waste product, urea, uric acid, and creatinine, there is clinical disturbances like anorexia, nausea, and several abnormalities. Then because of decreased urea excretion, uremia persists, leading to metabolic acidosis, hyperlipidemia, hypertension, glucose intolerance, and also the catabolism leading to increased sympathetic tone by increased secretion of cortisol and adrenaline, anorexia and undernutrition because of these uremic toxins, and negative nitrogen balance appears, and electrolyte imbalance like hyponatremia, hyperkalemia, hypocalcemia, and hyperphosphatemia. And because of erythropoietin deficiency, anemia also appear as the stage of CKD progresses. And because of anorexia and nausea and uremic toxins, there is malnutrition also appears. So, what is uremia? So, uremia is actually accumulation of uremic toxins because of decreased excretion of fluid and several nitrogenous waste product. So, nitrogenous waste product get collected, and because of these nitrogenous waste products, several physiological abnormalities appears like endocrine and metabolic disturbances, gastrointestinal problem, dermatological and neuromuscular problem, hematological and immunological problem. Then uremic toxins are different type of molecule like urea, creatinine, uric acid, amines and peptides, then a derivative of aromatic amino acids. So these are complex molecule leading to multi-system dysfunction. So there are several factors contributing to protein abnormalities. So if the patient is approaching to dialysis, then because of inadequate dose of dialysis, there is hemodialysis related catabolism also appears, and because of inadequate nutritional intake, there occurs protein energy malnutrition, and because of metabolic and hormonal derangement, there is acidosis and comorbidities. Then, because of all these uremic toxins, there is chronic inflammation and leading to insulin resistance and several metabolic disturbances. So, because metabolic acidosis is important part of chronic kidney disease, so it occurs because of inability to excrete the acid load by the kidney, and as the dietary protein gets metabolized, it generates around 1 millimole per kg per day of hydrogen ion, and kidney must produce and excrete ammonia to maintain acid-base balance and prevent accumulation of dietary acids. As this capacity declines, as the stage progresses and this capacity declines, patient develops acidosis, and it is characterized by decreased serum bicarbonate level and decreased blood pH. So, what are the ill effect of metabolic acidosis? Because of acidosis, there is acceleration of the protein catabolism, impaired nitrogen utilization, development of renal osteodystrophy, decreased myocardial contractility. So, it leads to catabolic condition, which ultimately result in organ dysfunction. So now coming to renal osteodystrophy, as the GFR progresses, decreases around less than 25 ml per minute, there is increase in serum phosphorus and serum calcium decreases, and this stimulates the parathyroid hormone. And because of hyperparathyroidism, there is osteogenic fibrosis and osteomalacia. Because of vitamin D deficiency, active form of vitamin D is also disturbed, so these ultimately leads to vascular calcification and increased mortality. And phosphorus has to be decreased by serum phosphate binder. And because of there are two part of this mechanism, this management. One is reduction in phosphate load in diet, and another in binding of phosphate with the drug. And serum calcium, if it is low, it needs to be increased. So, what are the causes of malnutrition in CKD? Because of inadequate intake and because of some dietary restriction, because it has been found that protein restriction is useful in early stages of management of CKD, and because of anorexia, nausea, and vomiting, patients' oral intake is disturbed. Because of uremic toxin, there is hypercatabolism, and alternate metabolism and utilization and requirement of several nutrients is disturbed, and also acidosis is there that ultimately leads to anorexia, and several hormonal changes also leads to malnutrition. And different comorbidities, underlying causes of CKD like diabetes, cardiovascular diseases, and infection also contribute to malnutrition. And protein energy and glucose losses during the dialysis is also very important contributing factor for the malnutrition. So how we should manage the patient of CKD. So we can divide it in two parts. Like first is early stages of CKD, there is conservative therapy. So dietary modification and other drugs related measurements are done. And the other is an advanced stage of CKD. We need to do renal replacement therapy, and dialysis are of two type, peritoneal and hemodialysis. And if patient is willing, then we can also go for transplant, because transplant is always a better treatment option because of good quality of life in comparison to hemo and peritoneal dialysis. So, about conservative management, there is a, control of the contributing factor like underlying cause like diabetes, hypertension, glomerulonephritis, obstruction, cardiac failure, hypervolemia, and to avoid the nephrotoxic drug like analgesic, aminoglycoside, amphotericin B, cyclosporin, and several contrast agents. Then dietary modification like restriction of sodium, potassium, phosphorus, and protein, and to supplement calcium and vitamin D if they are found to be low. Then management of the acidosis by soda bicarbonate supplements. Then if there is hyperkalemia, then sodium potassium exchange resin can be used, and by hyperphosphatemia, phosphate binder can be used. And because of erythropoietin deficiency, there is anemia, so we need to treat it with the supplement of iron and erythropoietin. So, how the low protein diet benefits in kidney disease? It has been found that the protein, higher the protein intake, the more is the afferent vasodilatation, and this vasodilatation leads to increased proteinuria and kidney damage. So, by decreasing the protein intake, the afferent vasodilatation is decreased, and it ultimately leads to stabilization of the GFR and may retard the progression of renal disease. It has been seen that protein intake of 0.28 to 0.6 gram per kg per day. If this much protein restriction is done with the supplementation of essential keto amino acid, there is they help in slowing the progression of kidney disease. And if the protein intake is low, so it also reduces workload of the disease kidney by reducing urea, uric acid, and creatine, and electrolyte and phosphorus production that must be excreted. So as the kidney function declines, if we decrease the intake of these substances, the kidney load is decreased. And also prevention of accelerated nephron damage by excessive protein intake. As I already told, that because of afferent vasodilatation, there is increased filtration pressure in the glomeruli, and if we decrease protein intake, this pressure is decreased. And also it prevents calcification secondary to renal dystrophy, also promotes the feeling of well-being and postpone the need of dialysis. So based on the stages of kidney disease like creatinine value, we can guide the protein intake. So if the creatinine is less than 3, that means stage 2 or 3 kidney disease, protein intake should be around zero point 0.8 to 1 gram per kg per day. As the GFR further decreases, like stage 4 and early stage of 5, like creatinine of 3 to 6 milligram per deciliter, zero point 0.5 to zero point 0.6 gram per kg per day, low protein diet is useful. And if the creatinine is more than 6, like the GFR less than 15, very low protein diet can be useful, around zero point 0.4 gram per kg per day. But we also need to consider the effect of this much low protein diet and in development of protein energy malnutrition. So needs to be balanced. And at the stage of end-stage renal disease, if the renal replacement therapy is initiated, then as we know that because of dialysis, there is excess protein loss. So we need to supplement extra protein. So here the protein intake is around 1 to 1.3 gram per kg per day. So National Kidney Foundation has recommended like for GFR below 25, the protein intake should be zero point 0.6 gram per kg per day, and at least 50% of this protein should be of high biological value and low protein diet because it has been found in several studies that it may retard the progression of kidney disease. So this again several studies and meta-analysis showing that low protein diet is useful in delaying the progression of kidney disease to end-stage kidney disease. Again, lower mortality in those receiving low protein diet. So it has been found in useful in comparison to high protein diet. Now, coming to a systemic review of meta-analysis by of low protein diet in management of CKD. So it has been seen that 13% decrease in the progression of end-stage kidney disease who received very low protein diet. So low protein diet have been shown to have lower risk of progression to end-stage kidney disease in comparison to high protein diet, and they also slow progression to ESRD in very low protein group. And pool results indicate that trend towards lower all-cause mortality in those who received low protein diet. So now coming to the renal replacement therapy, it's used in advanced stage of acute kidney injury and in the late stage of chronic kidney disease, like in the stage 5. So as we know that there are two types of dialysis, peritoneal and hemodialysis, and hemofiltration is another mode of hemodialysis. AV fistula and veno-venous, arteriovenous and veno-venous hemofiltration is used, and better treatment option is renal transplant, cadaveric and living type of kidney transplant. So these are different type of renal replacement therapies. Now coming to the losses during the dialysis, so we can see that around to 10 to 12% of the total derived nutritional protein is lost during dialysis, and glutamine loss is around 20% of the total amino acid loss. So 2 gram per hour of dialysis associated with uh, loss of amino acid, glucose, and proteins and peptides. So we need to supplement extra protein in those receiving dialysis. Now, coming to cost of dialysis treatment, so because of several complications, many times patient is hospitalized. So there is cost of hospitalization, and because of associated blood-borne infection like hepatitis B and C, their treatment involves further costs and loss of income due to decreasing work capacity because you need to spend time in dialysis room, and loss of time, energy, and money of the accompanying person because the one person has to take care of the patient. So there are several cost issues in dialysis patient. So nutrition stage of patient at the initiation of dialysis is clinically significant respective of mortality and morbidity. It has been found that the patient having cachexia and very low weight at the time of initiation of dialysis is inversely proportional to the survival and well-being. So we need to have maintain good diet and avoid protein energy malnutrition before initiation of dialysis. So energy intake in during dialysis should be 30 to 35 kilocalorie per kg body weight, and protein intake should be 1 to 1.2 gram per kg body weight. Sodium should be restricted if the patient is also having hypertension. Fluids should be restricted because excess water removal may cause disequilibrium, And potassium restriction is also important part because hyperkalemia may be dangerous, and no phosphate diet should be given because hyperphosphatemia has several disadvantages. Now coming to the nutritional requirement in acute kidney injury, again energy should be 20 to 30 kilocalorie per kg body weight, and carbohydrate should be around 3 to 5 gram per kg body weight. Fat intake should be zero point 0.8 to 1.2, maximum 1.5 gram per kg body weight, and protein around zero point 0.6 to zero point 0.8 gram per kg per day in AKI, and during dialysis 1 to 1.5 gram per kg per day. And if a patient is receiving CRRT, like in hypercatabolic state, maximum up to 1.7 gram per kg per day protein can be given in AKI. Now, as the energy intake of 35 kilocalorie per kg body weight is associated with better nitrogen balance and recommended in a stable CKD patient with ideal body weight plus minus 10%. So, if the GFR is 25 to 70, and the protein intake should be around zero point 0.5 to zero point 0.6, and if it further decreases, then we will decrease it further. So, a different guideline like National Kidney Foundation and ESPEN guideline have their cutoff values for protein intake. Now coming to the several other electrolytes, like phosphorus should be given around 600 to 1 gram per day. Potassium should be around 1500 to 2000 milligram per day. Sodium around 1.8 to 2.5 gram per day, based on whether patient have hypertension or not. Then fluid intake should be based on the urine output and whether there is edema or not. So depending on physical activity, lean body mass, and these parameters should be decided. And dietary habits and energy intake should be kept into the mind. Now, coming to the different formulation, like essential amino acid with keto analog have been found to be useful in retarding progression of kidney disease. And if the patient is in hemodialysis, then as according to ESPN guideline, 1.2 to 1.4 gram per kg per day protein should be given, and based on National Kidney Foundation guideline, it's around 1.2 gram per kg per day. And in CAPD, the protein requirement is around 1.2 to 1.5 in ESPN guideline and 1.2 to 1.3 gram per kg per day in NKF guideline. So the different guidelines show some variability, but we can see that at least in dialysis patient, the protein requirement is high because of loss of protein during the dialysis process itself. So again, same slide. And fiber intake is also important part because of several complication like constipation and other things. So it's around 20 to 25 gram per day. Fiber should be given in chronic kidney disease patient, as it found to be associated with decreased inflammation, and all-cause mortality is also less with this much of fiber intake. So several sources of fiber should be kept in mind, and uh, because of the dietary fiber, there is they have antioxidant property, and they also protect from fermentation of indoles and phenols, and colonic microbial activity is also preserved, and because of this, dietary acid load is also decreased. So ultimately, inflammation and oxidative stress is decreased, and it leads to decreased cardiovascular risk, and infectious disease complication is also decreased. So we know that there are two modes of therapy, enteral and parenteral. So enteral nutrition is always preferred. It is always the first choice. And if the patient is unable to intake, we can go for nasogastric and gastrostomy tube supplement. And if the patient is unable to take, or is there any restriction for enteral feeding, then we can also go for parenteral nutrition. Uh, like several injectable amino acid formulations are available, which can be given during dialysis. So, what can be the barrier? So, one is the uh, because of lack of communication. So sometimes nutritional counseling is not done, but nutrition is very important part of management of CKD, and lack of specific knowledge and training about therapeutic options and different guidelines should be kept into the mind before advising the nutritional advice. So all patients should be counseled for nutrition. Nutrition takes place an important part of kidney disease management. So, recommendation, like as we already discussed, that in early stages, protein intake should be around zero point 0.6 to zero point 0.8 gram per kg with supplementation of essential keto amino acid. And if the protein energy malnutrition is there, then protein intake can be increased to 1.2 to 1.4 gram per kg body weight. And several guidelines have been published in this for this recommendation. And to summarize this, the poor nutrition is common in renal disease and has adverse consequences. And nutritional counseling is an important part of management of CKD and dialysis patient. Routine nutritional screening and assessment should be done for CKD and dialysis patient. Qualified renal dietitian must be included in the nephrology unit because we have found that there is lack of counseling, dietitian can take part very important role in this management, and personalized nutrition plans should be planned because every patient is different and every patient's requirement and cultural beliefs are different. So we need to individualize the plan. Thank you.